Cameron, you can go ahead and share your screen with your PowerPoint. There we go. Great. Okay, we want to welcome everyone to our November educational session for GRAC. And my name is Pamela Mahan, and I'm the programs chair. And we're so glad to have everyone here on this evening. We got a great program planned for you. First, what I'm going to do is I just want to go over a few housekeeping issues. Make sure that everyone that's attending, please make sure that your microphone is muted. And just remember to remain online until the end because we'll be having a drawing at the end for some gift cards. And then also, we will also show the QR code that will link to the evaluation at the end of the program. You'll actually have 2 weeks, a total of 2 weeks to go ahead and to complete the evaluation, and there will not be an extension beyond that time. So make sure that you do go ahead and try to scan your QR code. There are directions up there, and I'll go over that with you at the end. If you're having problems with your phone, just go ahead and email me at programs.grac.aacn programs.gracAACN@gmail.com, and I'll have the email up for that. And I'll make sure that I'll send you the link to the evaluation. So we will be giving away 1 student membership to AACN and to our local chapter. All right, and so now I'm going to go ahead and I'm going to read Cameron Jennings, her bio. Cameron Jennings is an advanced practice nurse at McGuire VA Medical Center, serving in a dual role in the hospice and palliative care program. She divides her clinical time as a palliative care consultant for the medical center and as the primary provider for the inpatient hospice palliative care unit. She is ANCC board certified as both a family nurse practitioner and a public community health clinical nurse specialist. She is passionate about healthcare, and while she initially graduated from Temple University with a bachelor's degree in journalism, public relations, and advertising, the nursing bug bit her, and she went back to complete an associate's degree at Reynolds. Associate's degree in nursing at Reynolds, followed by a BSN and MSN from the University of Virginia. She holds certification as an advanced certified hospice and palliative care nurse and is proud to be a founding member and chapter treasurer for the Central Virginia chapter of the Hospice and Palliative Care Nursing Association. In her free time, she enjoys being outside, watching and playing soccer, kayaking, and spending time with her husband and 15-year-old hound dog. So let's just give a warm welcome to Cameron. Thank you, Cameron.
All right, we're gonna get rolling. Hopefully everybody can hear me well. Please feel free to use the chat box. I wanna make this as interactive as possible, certainly within the confines of Zoom. So thank you for having me. It's my pleasure and honor, and I know you guys are all very busy, so we'll get started. So I wanted to kind of do a quick dive into palliative with a little bit of focus on critical care. I have no conflicts of interest. There's my hound dog. And objectives really to understand the role of palliative for patients with serious and life-limiting illness, to differentiate between hospice and palliative, and then identifying key interventions for patients and their families. So this is kind of where I want to see where you guys are. So when we say palliative care, what comes to mind? I know some folks are joining virtually by phone, but if you're typing in, if you can kind of share just in the chat box, what comes to mind when you hear palliative? Comfort measures. End of life. End of life. All right, we'll give a couple more. Symptom management, symptom control. All right, goals of care, comfort management, chronic disease management, pain control. All right, symptom management and goals of care. All right, so a good mix. Thank you, Shanna. And again, wanted to hear, you know, so what really makes this so difficult? You guys all seem to have some experiences or from the chat so far. So really, what makes this challenging? Pop it on in the chat box. Lack of patient provider education. Okay. Patient goals. Our culture doesn't speak about this. That's right. We don't get sick or seriously ill. Patients and families don't understand, unrealistic expectations. We don't start enough, soon enough. Awesome, so thank you. So absolutely, I think especially in the critical care setting, we have medically complex cases with a lot of moving parts. There's a lot of emotion involved from both the patient and family side, but also our own emotions as a team member, as a caregiver. And a lot of times we may not know what to say. There's also a level of uncertainty, especially in hospitalized seriously ill patients, where we don't know what's happening next. And we don't know maybe what the prognosis is, or we don't know what the trajectory may look like, or what the next treatment is on the table. So all of these things can make things really challenging. Specific to critical care, many of you all had mentioned some unrealistic expectations, especially in intensive care therapies. And sometimes those unrealistic expectations come from ourselves, but patients and families as well. Many times there's a misperception that palliative care and critical care can't go together, that they're sequential and not complementary. And we'll talk a little bit more about that. Conflation of palliative with end of life or hospice care. And I think we want to really look at that a little bit more, because I do think in the critical care setting, they're more intertwined in that we deal with more serious illness or potential trajectories that are really life limiting in that moment or within that admission. So a lot of times, even though by far and in general, palliative and hospice are not equal, for the consult in the intensive care setting, a lot of times we might be dealing with end of life. Concerns that palliative incorporating palliative would hasten death. Insufficient training, I think we hear that. Competing demands on ICU clinical efforts. So managing and titrating drips and starting pressors and those things, sitting down and having a goal of care conversation may not be on the forefront. And the culture of our system, as somebody mentioned in the chat box, you know, we kind of, the goal is to cure and heal and improve that clinical care situation and then move on. And so a lot of times we don't carve out that space to really know what our patients and families want. So palliative comes from hospice, actually. The origins really generate from hospice care. Dame Cicely Saunders, who was one cool lady who was a nurse and then a social worker and then trained as a physician as well. She founded the first formal hospice in 1948 with patients with terminal illness. Pallium comes from the word cloak, so kind of thinking about that, embodying and covering. World Health Organization recognized palliative in 1990 as a distinct specialty dedicated to relieving suffering and improving quality of life, specific for patients with life-limiting illness and serious injuries. Over time, we've seen a growth in palliative care within hospital beds, usually with more than 50 beds. So in 2011 to 2000 to 2011, there was a big boost and boom in palliative care offerings in larger hospitals. And then more recently, most hospitals with more than 300 beds have a strong palliative care program. So really palliative is appropriate at any stage of a serious illness, and can be beneficial when provided along with curative and life-prolonging intent treatments. Really the focus is on what's most important to the patient, family, and caregivers, and a big part of palliative is assessing goals and preferences and really determining how to best achieve them. So matching what patients' goals and wishes are with a care plan that can be incorporated while they're hospitalized and ongoing. And when we think and look at about serious illness, oh goodness, hang on, there we go. Serious illness is really defined as a health condition that carries a high risk of mortality and negatively impacts a person's daily function or quality of life, or impacts and strains the caregiver. So this is kind of the old versus new model of palliative, and I have a little bit to say about that because I think we still operate a lot within this disease-directed care model. The goal is really to incorporate palliative during active therapy while people are getting disease-directed treatments. Usually in the beginning of a disease process, maybe there's less symptoms and there's less need to address things. And as the disease progresses, palliative care role can increase and be involved. And then there's that potential for transition of hospice care, being immediately involved at end of life, and then ongoing bereavement support. The old model, which I feel we're still kind of enmeshed in, is do everything we can from a disease-directed standpoint. We've run out of tools, consult palliative and have them jump in. And that really disservices our patients. But I do think that upstream palliative is growing. We're seeing it more in the clinic-based setting. But within critical care, I think we're oftentimes getting called when things are really kind of at dire straits. So key components of palliative really are multi-tiered. So symptom management, we often think of pain, dyspnea, nausea, delirium, anorexia and fatigue, anxiety, depression, but also the psychosocial and spiritual support. So involving our team members with counseling, with social work and pastoral care. Our chaplain service is a great asset. Caregiving support and bereavement. So really addressing that component. And then a big part is decision-making. Prognostic awareness, really, patients and families can't make decisions on where they go if they don't know where things are. So it's our responsibility to kind of make sure that we paint that picture and that everybody's on the same page, and then we can come up with a good plan of care together. And then do families and patients really understand the outcomes of their decisions, and are they able to define what good quality of life is or what meaningful recovery may look like? And we do this by pulling out kind of goals and values with our patients through one-on-one conversations and family meetings. So I want to talk a little bit through a couple cases. So this was a consult, goals of care in the setting of end-stage renal disease and end-stage systolic heart failure. All right. So when we look at illness trajectories, I don't know if you all have seen this slide before, but I think it resonates quite a bit with me in terms of knowing kind of what we're looking at. So that end-stage heart failure and end-stage renal failure, that person has had this long trajectory of disease with both of these chronic progressive diseases, likely many admissions and exacerbations with some overall decline. And then we're getting into where there's that decline where kind of admissions toward that end could be very severe or significant. So this is Mr. R. Sorry, here we go. So Mr. R, he is a 72-year-old gentleman with non-ischemic cardiomyopathy. He's had bivalve heart failure for 12 years with paroxysmal aflutter. He's had issues with arrhythmias and has an AICD, sleep apnea on CPAP. He's got pulmonary sarcoid, BPH, GERD, end-stage renal disease, and restless leg. He previously declined an LVAD in the setting of advanced renal disease. after talking with his cardiology team and his renal team. He ended up coming in and having to start hemodialysis kind of urgently during a hospitalization the month prior. And only a couple weeks after starting and being discharged, he had significant dyspnea and orthopnea during a hemodialysis session and was sent to the ER. He was found with elevated troponin, with demand ischemia, elevated BNP and lactate, leukocytosis, rate controlled aflutter. He was started on a heparin drip. They couldn't really diurese him because of hypotension. He was started on midodrine. He ended up getting admitted to the ICU with decompensated heart failure and cardiogenic shock, started on low-dose low-dose inotropes for support. Renal was consulted to follow for dialysis needs, and the thought was that his arrhythmia was causing worsening decompensation of his heart failure, so when he stabilized, the plan was to cardiovert him. No advance directives on file. He's listed as a full code. So that's kind of the chart review, and then going to meet Mr. R. He was actually pretty insightful to his disease, which is not always the case. He was able to really narrate recent events and progressive symptoms impacting his quality of life. This gentleman was a Marine veteran for 24 years. He had a long-standing government job until just a few months prior. He was working up until the point where he was admitted for where he started dialysis. He's divorced and remarried, and his stepdaughter is very much involved in his care, as well as his current wife. Quality of life for him, he talked about, was going to movies, woodworking, gospel music, and sitting down and meeting it with him and looking at his symptoms. He had a significant amount of fatigue and weakness. He had baseline insomnia that was exacerbated by being in the ICU, because who sleeps in the ICU? Respiratory wise, he had exertional dyspnea, cough with expectoration. GI, early satiety, which we oftentimes see in end-stage illness. We're just getting full quicker. He had myalgias and polyneuropathy. So kind of a lot going on. And I want to take this time to talk about, we said that he had no advance directive, and we looked at his family. So he is married. And one of the biggest challenges, I think, is who are we talking to? Who are the right folks? So this gentleman is able to make decisions, but what if during the course of his illness he's not? Who are we talking to? Who are we involved with? And knowing that folks that are really sick can transition and change quite quickly, really encouraging them to involve key stakeholders in conversations early on so that families know what's going on before things change and patients are not able to make decisions. So I won't go through the long list, but I've been involved in more than one case where we're really talking to the wrong person. There's, a daughter that's really involved, but the patient's actually married. And so the person that's going to make that decision maker is decided by law if we don't have a directive naming a healthcare power of attorney. So just making sure that we know who we're talking to and getting good information. Really the hierarchy in Virginia, which would differ from other places, is a guardian, then the patient's spouse, and adult children, a parent, and then adult brother or sister, and then kind of relatives in descending order by blood. So again, a stepdaughter would not necessarily be the next person to make decisions, even though that person might know them best, which is really a good reason to complete advance directives. In Virginia, also, if there are 5 different siblings or 12 different children, each of those members has equal stake in making decisions. So it can get a little messy when we're talking big families and goals of care. So this is one of the tools we use. It's called the Palliative Performance Scale. And really it kind of looks at where people are on a trajectory and a path, weighing things like ambulation, activity level, that kind of shows us evidence of disease, their ability to participate in self-care, their intake, how much they're eating and drinking, and their level of consciousness. And a lot of times over time with chronic disease, we'll see a slow decline. And with acute disease, we may see that somebody goes from one level to another very quickly. So this gentleman, a couple of months ago, he is working. He has a little bit of difficulty and he's actually having to work from home, but he can still take care of his ADLs and meet his own needs. And as his disease has progressed, he is really sitting and lying more. He's having to take pauses in his activities. He's not getting out and walking. And he needs some more assistance around the house that's provided by his family. So in sitting down and kind of talking and again, presenting ourselves as, we don't have an agenda, we're really trying to kind of explore what's, where our patients are coming from. He was really concerned about illness severity and how quick this came on. He felt like he was doing okay post last hospitalization, and now all of a sudden he's back in the hospital again. He shared that he needs more help at home, which was a little bit hard for him to admit. And a big regret about not retiring, that he should have spent more time at home. So again, regrets and laments about, now that I'm here in this place, I don't feel like I valued as much of my time in the past. And this was a case during COVID. So frustration about this disconnect with family related to visitation restrictions. He shared that his wife came to every appointment with him, and the fact that she had to kind of be there on the telephone. She didn't have a smartphone, and she didn't have technology to do FaceTime or Skype, was hard for them. He did endorse good support from family and a strong sense of faith. So kind of on meeting one, we're getting the background, the primary team's doing what they're doing, and really he wanted to focus on his insomnia. So we optimized his sleep with a replacement CPAP mask while he was admitted, rotated his restless leg medications to an appropriate time, scheduled melatonin, tried to optimize sleep hygiene as much as we could within the ICU setting, and increase his neuropathic pain medication at bedtime. On follow-up, the patient really felt like things were dire, and that he was concerned he would not make it out of the hospital, which was a very realistic thought, given the level of support he needed for his blood pressure. And what he identified as his primary goal was to make it home, to spend time with family. He wanted to be as independent as possible, but he knew he would need more help. And his real priority was being mentally clear. So being able to have meaningful interactions, which is a common thing we hear from patients, not just to be present, but to be able to meaningfully engage. He was very much open to a family meeting to really discuss, does the team think things are as severe as I'm feeling?
Cameron, can you hear me? We're getting a lot of background noise. It almost sounds like somebody's leaning on their computer.
I haven't done anything different. I'm not sure. Oh. Is there anybody else with a mic on? Sometimes that'll do it.
Is anybody else hearing it?
No.
Okay, maybe it's me. Okay, it's my computer then. Sorry.
No worries.
Continue.
Thanks. So in sitting and talking with this gentleman at bedside in the ICU, a lot of emotions are coming out. And one of the tools that we can use that's really simple, has a great acronym, it's NURSE. So naming, understanding, respecting, supporting, and exploring. And so these are tools that we use when we're eliciting emotion and we're picking up on that emotion. So a lot of times, it sounds like you have a lot of regrets with how you've spent your time over the last couple months. Or, I see that you and your family have done everything that you can to keep you, to keep your medications on board and to keep you out of the hospital. We're here to help. And then exploring, one of my favorite tools to use, this example says, could you say more about what you mean? But just the words, tell me more. A lot of times people speak in metaphor, or we don't really know what their statement means. And so without assuming anything, just tell me more a lot of times, or can you tell me more about that? Really lets us understand and keep that conversation moving forward, and let patients share a little bit more about that emotion. So in kind of setting up and planning to have more of a care goals meeting, Ariadne Labs and also Vital Talk are really good resources for serious illness guides. And a lot of this is patient tested. They've actually done trials in tested language to see what works best. But we treat this like a procedure that really it's a tool and it's a skill to learn so that it goes the best that it can go. So really it's about setting up a conversation, and this involves a quiet place, having the right folks there, and asking permission is also a really powerful tool when we think about patients, especially in the hospital setting, that have, loss of control, maybe loss of physical or function. Asking permission, is it okay if we talk about this? That gives a little bit of that power back, and that can be a really meaningful way to build rapport with your patients. Or giving choices, even if it's, is now an okay time, or can I come back this afternoon? Again, assessing and understanding preferences, kind of like a roadmap. You would never give somebody directions to short pump if you didn't know where they were coming from. If they were coming from Richmond, it'd be different than if they were coming from Charlottesville. So we've got to know where they are before we put things out there. And sharing prognosis, I think, is a really tricky tool. I think a lot of times when there's multiple specialists involved, people may have differing opinions on that, but we owe our patients our best assessment of where things are, with the caveat that we may be wrong, but we're concerned that time could be short. Or we wish we weren't in this situation, but we're worried that things may not go as planned, or that you may not leave the hospital. Silence a lot of times feels like an eternity, but allowing those pauses, allowing folks to kind of sit there for a moment is a really powerful tool as well. And so when we explore those key topics, we're going to make sure that we document this, and we're going to make sure that our colleagues and other folks know kind of if anything changed or what we discussed, because a lot of times these care goals conversations are not done in silos or by themselves. It's not a one and done. So we may need to follow up and make sure that the right folks know and understand where things are. As nurses, I would encourage all of you, if there's opportunities to be involved. A lot of times the group comes in, they have a meeting, everybody leaves, and patients and families are left with, help me remember what that was. And so a lot of times our best allies are our bedside nurses that are continuing care and can really kind of reinforce some of those things, or maybe come back to the team and say, hey, I know you guys talked about this, but I don't think they understand, or whatever it may be. So this is also not an uncommon situation. So he had his cardioversion, he was stabilizing, and the team said, nah, we don't need palliative anymore. And so that can be really frustrating. So the plan was, I think we can get him out of the hospital in a couple of days, and we're just going to bypass this whole goals of care thing. However, he intermittently was not tolerating dialysis. He was still requiring inotropes on and off. The team was getting really frustrated that they couldn't get him fully off of inotropes. And then within cardiology, they were trying to decide if home dobutamine made sense with a PICC line while also pursuing dialysis. So kind of how chaotic would that look like at home? So they reached back out. We encouraged kind of care goals conversations with the patient and family after we pre-met within cardiology and the outpatient heart failure team and renal to kind of get all the key stakeholders on the same page. And everybody agreed that the burden and risk for infection was going to outweigh the potential benefit for this gentleman for long-term inotropes. So here's kind of another example of patient-tested language and some of the kind of more details of how we would walk through an actual family meeting. So we sit here with really good understanding of illness severity because there had been that time where there was ongoing communication from the primary team with the patient and with the family. We addressed that uncertainty of not knowing exactly what would happen, but we were at that juncture, it looked like we could get him off of the inotropes. We spent a lot of time exploring hopes and fears, which are really two sides of the same coin and should be involved in that. And understanding trade-off, the patient absolutely was willing to come back and forth to dialysis, but he did not want to be rehospitalized again. He did not want to spend time in the ICU again. And so we were able to frame recommendations based on what he identified as most important. Number one was time with family. He already felt like he didn't retire early enough. He was in a new relationship with his wife, who he really enjoyed spending that time. He wanted to be in the home setting. COVID really exacerbated this. Being away for that short amount of time when time could be short was really not good for him. And he wanted to have good symptom management. All reasonable things. So we kind of laid out two different pathways that we could go and tried to make it as easy and straightforward for the patient. A lot of times we tend to offer kind of a la carte things that may not go together in a comprehensive care plan. And I think we owe it to our patients to kind of make sure that things match up. So the first plan was kind of what we were doing. It was the status quo. It was continue dialysis, continue home health aid service, optimize equipment for energy conservation. When and if things change, he would come back to the hospital. The asterisk is we may not have more tools to offer you to bring about good recovery. And this was really in line with his current care plan. And within this conversation, he really shared preferences regarding resuscitation and being in the ICU and being on machines. And so we did kind of broach code status within that and the role of his current ICD. Plan B was laid out as really more of a hospice care plan. So he can continue hemodialysis. This shocks some people, but his hospice diagnosis is his end-stage heart failure. So he can have concurrent dialysis for his end-stage renal disease. Home health aid and equipment for energy conservation. And really as clinical changes arise, symptoms are managed in the home setting and he's not coming back to the hospital with the help of the home hospice team. So we'll talk a little bit about hospice as far as how we differentiate between the two. So hospice is a plan of care. It's also a Medicare it's actually a benefit that patients have. So really when you hear about hospice, it's a program of care and support for people with terminal illness. So if a life-limiting illness is deemed to be 6 months or less, if it ran its natural course, the goal is to manage symptoms. It can be used for several different diagnoses in terminal diseases, dementia, cancer, stroke, heart failure, end-stage lung disease, ALS. So not just cancer. The focus is on comfort, not curing illness. It's usually provided by an interdisciplinary team. Medications are paid for related to the terminal illness and condition. So if somebody had cancer-related pain, but they needed constipation management, those things would be covered by hospice, as well as home equipment and things like that. Care is generally given in the home. This can also be done in nursing facilities, assisted living. There are inpatient settings. But generally in the home and generally by family members. So there's additional supports for families, but I think there's a misnomer that hospice is coming in and doing a lot of the care. Hospice is there to support the family. And so a lot of times caregivers are needed to be able to provide a lot of that care. And we run into the situations where maybe the patient is elderly and so is their caregiver and they don't have extended family. So that can be really tricky. And I think we have to be honest about what it is and what it's not sometimes. It's not kind of always the best route for patients when there's not a lot of support in the home setting. For Mr. R, he opted for home with hospice services. He left the hospital with a durable DNR form and deactivated his AICD on day of discharge because it was congruent with his wishes. We prescribed low-dose opioids for shortness of breath and provided patient and family education. This case, actually, I followed up fairly recently. He's still able to be back and forth to dialysis. He told his primary care provider he feels at peace with his decision and with his care plan right now. He feels well supported. And the next step really would be, you know, as he's clinically changing the benefit versus burden of coming to dialysis with his renal team. Sometimes renal will do palliative dialysis, meaning they'll help with symptom management and cut back to maybe 2 days a week or shorter courses. So this is something that was possible because his clinical status evolved. So kind of looking back, you know, our role is no agenda and really wanting to be helpful. And I say no agenda meaning the outcome of what he decides and what his family decides is not what we're concerned with. We want to make sure that the patient and family have all the information to make an informed decision. In this case, conversations were held over the course of several visits in context of the clinical situation, team and engaging key stakeholders. This team needed a lot of support. The outpatient, the cardiology team that had also been taking care of him saw him in clinic, and this was hard. They felt like they were giving up. But patients with end-stage heart failure do go on to hospice sometimes, or, you know, folks do decline from these illnesses. And so I think optimizing symptom management while goals of care were evolving. And so some of the what ifs, I think, you know, if he lost capacity during this course, which was very likely given his level of illness, who really knew what his wishes were? Would family have been able to make that same decision on his behalf? What would things have looked like if we couldn't wean the inotropes? We would be having very different care goals conversations. And, you know, especially in his case, what would more upstream palliative care look like? What if, you know, we could get better symptom control and some additional home services in place, you know, prior to this last admission? I'm trying to move stuff around to see if anybody has. Are we still okay with hearing? Pam, you want to give me a thumbs up?
Yes.
Okay. Just want to make sure everybody's on the same page. All right. So kind of back to that disease-directed care, and like I said, the goal and really the movement is to have more upstream palliative care, but a lot of times we're still stuck in this disease-directed care, kind of that wedge of palliative, and then hospice right at the end. So I think we can all do a better job, but again, all those barriers are still in place. So our second case is Mr. W. The consult was goals of care and symptom management for new T-cell leukemia. So this gentleman came to us he's a 68-year-old gentleman, newly diagnosed T-cell prolymphocytic leukemia. He was actually worked up in an outside hospital and transferred as a second opinion directly to the ICU. So his course started where he was very much mobile. He was traveling from New Jersey to see his son. He was admitted to the outside hospital with generalized weakness and diarrhea. That was his only presenting symptom. His workup revealed white count greater than 200,000, dehydration, AKI, lactic acidosis, and a non-STEMI. He ended up having extensive workup, including bone marrow biopsy and cytogenic testing. He had a massive drug reaction and was treated for rash, respiratory failure, and he had some clinical improvement and stability. Palliative care actually saw him at this outside hospital for goals of care, and it seemed to be a fairly short, straightforward consult. He elected for all life-prolonging interventions, full code status. Also, no advanced directives on file. He does have an adult son who is his next of kin. So digging in further, Mr. W has a pretty limited medical history, hypertension, BPH, treated stable prostate cancer history, heavy remote tobacco use. He was a Vietnam veteran. He worked as a lab supervisor for 20 plus years before recently retiring. And he shares his time between New Jersey with his sister and his son, who is down in North Carolina. And when I went to see him at the bedside, he was very sleepy and fatigued. He really couldn't report symptoms other than being very tired. And he did say he had no pain. On exam, he was very cachectic. He had bitemporal wasting, so kind of the muscles around his face at the temple area were wasted. Dry mucous membranes, diminished breath sounds on 5 liters. He was not tachypnic at the time, heart rate in the 90s, pretty significantly hypoactive bowel sounds, and significant lower extremity edema. Found out that he had not had a bowel movement in 5 days. No family at the bedside. They preferred to wait on any goals of care conversations until they arrive. This was pre-COVID when families could come and we could sit down at the bedside. So just that caveat with COVID, I think the communication and the challenges of staying connected and for families to really know and understand what's going on is that much more difficult. So kind of impressing on you all, I know using technology, Skype, FaceTime, Zoom, all sorts of different mechanisms, window visits at times are helpful. And I know visitation varies at different places, but making sure that key stakeholders are as involved as possible. So, excuse me. So back to that illness trajectory slide. So this is really kind of the top slide where a lot of times we see cancer. Sometimes this drop in this decline is with a diagnosis of cancer is in years. In this gentleman's case, it's really weeks to months where he's had this rapid decline. We're helping with symptom management. So it's multifactorial. He hasn't taken in a lot. He's dehydrated. He's not moving around as much. We found out that he did not have obstruction. So really the goal is to get his bowels moving as soon as possible and then establish a bowel regimen. He was able to take things by mouth. We know that body makes waste product even with decreased to no intake. So people still need to have bowel movements. Us nurses love to talk about bowel movements. So he received a physical suppository with result, and then we just started on oral senna, and he was able to take that and maintain. For that really dry mouth, again, can be from medications, from the disease process itself, from being dehydrated. So for him, scheduling artificial saliva before meals and then as needed, and making sure he had really good oral care seemed to help with intake a little bit. It can actually make food taste a little better. I'm gonna get on a soapbox now. DocuState. Oh. So this is actually a great article. I wish I wrote it myself, but things we do for no reason, prescribing DocuState for constipation in hospitalized adults. So DocuState, we use it a lot, and there is no great rigorous scientific evidence that it is effective. Multiple randomized controlled trials have failed to show any significant efficacy over placebo for constipation. And it is a stool softener, is not a laxative. So more recent and more robust studies really found evidence to support use of polyethylene glycol or Miralax, lactulose, or senna-sides. So if we're trying to get patients to go to the bathroom and they are constipated, please throw the DocuState out the window and give them something that they can actually use to mobilize their bowels. All right, I'm off my soapbox. So follow up with Mr. W, and so we've got his bowels moving, and the team's got him on fluids and antibiotics and light correction and trying to figure out next steps with this really intense, severe cancer that is unrelenting and there's no great treatment for. And I come to see him, and he is saying, yeah, and he's briefly consolable, and then he's resuming, and it's just yeah over and over. He's looking around the room, extending his arms out and grabbing, and he looks like a completely different man than I saw the day before. So what's going on? So I know ER and ICU both have different versions of the confusion assessment method, or CAM, but it's usually a quick and easy way to diagnose delirium with a high predictive value. So presence of acute and onset and fluctuating discourse, check. Inattention, check. Disorganized thinking, absolutely. Altered level of consciousness, yes. So kind of a, acutely very much different than how he looked, but also critically ill. And so delirium a lot of times is very common with serious medical illness, more so in the ICU. There's tons of studies about ICU-induced delirium, but when we deal with serious illness, we can see this across kind of practice settings. Hyperactive, hypoactive, or mixed types. We always want to look for reversible etiologies. So he was on infection management treatment. We dealt with constipation, urinary retention is being monitored. Are there medications that are contributing? We're doing light correction, and is sleep deprivation a big part of that? There are no great meds for delirium, and we'll get into meds in the next slide, but environment is really key. So can we provide day and night cues, help maintain that sleep-wake cycle? So bright lights during the daytime, nice and quiet and dark in the evening. Try to optimize schedule and routine as best you can. Avoid over or under stimulation. So talking and interacting with patients can help, but minimizing alarms, blaring TVs, hallway noise. Temperature control, so is the room really cold? Is a warm blanket or a fan helpful? And then just good skin and wound care, keeping folks clean and dry, offering food, fluids, oral care as needed. So medication management, really pharmacologic interventions may be needed for patient and staff safety. So getting up, aggressive behaviors. And for comfort, delirium is a high predictor of mortality. And sometimes we do all those reversible, address all those reversible things, and we're still left with delirium, especially toward end of life. So we think about medications that we use in the hospital setting, first generation antipsychotics like Thorazine and Haldol, second generation antipsychotics. So I'm rattling off names. The challenge with second generations are they're all by mouth. So people are not taking PO meds. We're usually using IV or sub-Q. As a rule, for palliative, IM injections are an absolute last resort, and we would not use IM routes because they cause more harm, cause more pain and discomfort. But if we really need to use them, it would be a last resort. Caution with Haldol, you would avoid it in Parkinson's or Lewy body dementia because it can exacerbate those symptoms. So if someone's able to take PO, Seroquel is kind of that first line for antipsychotics for Parkinson's and Lewy body. And with the second generation and first generation, we look at all of the things in competing issues with side effects. So QTC prolongation, EPS effects, orthostasis, and sedation potential. Low doses of these medications typically are not sedating, but we can pick and choose if we need somebody to get a little more rest. And these should not be used just for insomnia at night. I mean, they really should be used for agitation and delirium and with a thoughtful eye. The black box warning for antipsychotics is related to dementia-related psychosis in elderly patients. And it really doesn't address the short-term use of antipsychotics to manage delirium, especially with folks with serious illness or at end of life. Benzodiazepines have the potential to make delirium worse and precipitate withdrawal symptoms, but quite honestly, we use it a fair amount when there may be a contraindication to first or second generation antipsychotics. Sometimes when we think that dyspnea and anxiety are potentiating delirium, that can be used in mindful dosing. There's actually a fair amount of study more recently that melatonin can help prevent delirium for at-risk hospitalized patients by regulating sleep-wake. And so that would be given kind of to prevent or in conjunction with other management. I'm sure everyone has a tool when patients are not able to verbally report pain. We end up using PainAd quite a bit, which is pain assessment in advanced dementia. But it's a good tool to kind of really, in describing with families sometimes that, hey, we're still assessing pain even though your loved one can't tell us. Sometimes narrating what tool you use and what you actually look for can be really helpful. It's not that we're not doing that, but I'll tell families, you know, they're breathing very comfortably. I'm not hearing any negative vocalization. There's no moaning or groaning or any tension on the face. They're resting, you know, comfortably, nice and relaxed without any tension or pushing back, and whether or not they're able to be consoled or not. So a lot of times narrating what those tools you're using, whether it's this one or another nonverbal assessment for patients, so that families know that we're still doing those assessments. So for Mr. W, we're still we're managing symptoms, but we're looking at this family meeting. So pre-meeting first, again, is the medical team on the same page? And unfortunately, you know, this was a case where oncology and all the primary team, kind of everybody agreed that, you know, this was a life-limiting cancer, and as a second opinion, there wasn't a lot more to do. And that was really hard for the team to kind of say. In this situation too, the key stakeholders were not only the patient and his son, there were 3 sisters, not just the one in New Jersey, and 2 cousins that were actively involved, and everybody wanted to be at each and every one of these discussions and family meetings. So we really need to make sure we know who's involved and not leave anybody out. If somebody needs to be on Zoom and somebody else needs to be on the phone and somebody else needs to be at a window, we try to accommodate that to make sure that the right folks are there. Like we talked about, kind of carving out that time and space and treating it like a procedure. And in this case, attending to the emotion was really important. This family was still in shock. This was a man that was traveling back and forth up and down the East Coast. He works on cars. He's the nicest man you ever met. He would help anybody off the street, they said. So why is he being punished? Why is this happening to him? And they could not get past that this was so quick and so fast, and he was such a great person. Why? And so kind of sitting with that emotion, and again, using some of those tools we discussed earlier. And they got a lot of comfort out of being able to talk about him, not as the delirious man in the hospital bed, but as this great and amazing guy. So I think if we have that time to pull up a chair and really listen to our families, a lot of times that helps them, you know, makes us more personal, makes us understand who our patients are, who we're taking care of. So Mr. W was obviously not able to participate in this decision making because of his delirium that was not, you know, and the discussions needed to happen kind of during that time frame. So we talked about care options with the family, and they were very much open to kind of changing code status and exploring kind of DNR and DNI. So if his heart stopped, they wouldn't want him to go, you know, be put on a breathing machine and allow natural death. But they kept saying, I don't want to take anything away. So he's getting IV fluids and antibiotics and blood transfusions, and his edema is getting worse. But we don't really have, you know, nobody wanted to stop those things, and they didn't want to take anything away. They agreed with, you know, aggressively managing symptoms because he did not look comfortable. I spent a lot of time exploring hope and what they hope for him. And chaplain support, because of their strong faith and spirituality, was really key to kind of understanding their perspective from that. And I wanted to step back. I failed to mention kind of this idea of total pain earlier. That was something that when we talked about the awesome Cicely Saunders, this idea of total pain as kind of a physical, emotional, social, and spiritual distress. And so when we're managing pain, managing that total component, and I think when we're managing patient symptoms, we want to attend to those needs as well. So I think involving our interdisciplinary team, whether it's for our patients themselves or for the family, to kind of tease out some of those distresses and concerns. For delirium management, we provided staff education on how to best assess for delirium and kind of keep the patient and them safe. Trialed a now dose of Haldol that was actually effective, so we scheduled, that was in the afternoon, we scheduled it for bedtime, and then he had PRN available through the night. On follow-up the next morning, he looked very comfortable. He had received a PRN dose of Haldol for delirium and then 2 doses of IV Dilaudid for nonverbal signs of pain per our pain ad assessment. It was also in for dyspnea, which we'll talk about a little bit more. But the patient is not responsive. He's noted with retained oral secretions. He's got a new Cheyne-Stokes breathing pattern. His face is calm. He's not agitated. Family members that were not the son came to the bedside and they said, what can we do about his edema? And so back to that responding to emotion. So tell me more. What is it that about that edema that's bothering you? So tell me more. Or I wish there was something we could do about that. That's really coming from this disease process itself. Using those other tools, I'm afraid we're at a different place right now. So fast forward to kind of multi-tiered approach to further discussions and to managing symptoms. So education and anticipatory guidance for family at bedside, really talking about these symptoms are indicating end of life. Additional chaplain support for bedside prayer. With the primary team, contacted the patient's son because he was not there, discussed what we were seeing, concern, afraid that time is short, aggressively kind of managing secretions and continuing to manage dyspnea and tachypnea. One of the most useful tools that we seem to have and families and help understand changes. I would say that most families, you talk to one family, you've talked to one family. There's families that have had tons of experience with end of life. There's families that have had no experience with end of life. Or they may have had varied and very different experiences. So it's not a one size fits all. So being present, I think a lot of times we tend to think that families want that time alone, but asking them, is it helpful if I share what we might see over the next couple hours? If a private room is available, that is ideal to give them that space. And use of the little blue book, which is an educational handout. This was written in 1986 by an RN. We use it still to this day in kind of an edited format. But it really talks about the stages of dying process over months, weeks, days, and then the hours. And there's kind of a little outline of what folks might see. Very widely used. I don't know if you all have had that experience or have seen that in your practice. Dyspnea management, again, we'll go quickly through. So subjective feeling, in nonverbal patients, we're gonna still assess for tachypnea and accessory muscle use of the chest, of the abdomen. Oxygen, if they're hypoxic, it's not proven to improve or be beneficial. If not, a fan or cool air across the face can be as effective. And nebulized routes of opioids are not proven to be more or as effective, and they do not have less side effects. We've gone I think the thought a while ago was that we could try that and give little doses. They're not systemically absorbed, so avoiding nebs. If somebody really is truly dyspneic, they need systemic opioids, not the inhaled version. Goal is to provide symptom management, not to cause death. It feels like it shouldn't have to be said, but gold standard for dyspnea at end of life, as well as dyspnea refractory to treatment of underlying causes. And much like we use opioids for pain, if there's renal impairment, we should really avoid using morphine. Opting for fentanyl or Dilaudid is going to be a little cleaner and easier on the body, less side effects. For acute and severe dyspnea, use of parenteral, whether it's IV or sub-Q, is the route of choice, and we may need to start continuous infusions. Several studies show that patients are more likely to receive opioids as they get closer to death, with the change in symptoms, with the change in what the body is doing. There is no evidence that initiation of treatment or increasing the doses appropriately, the caveat is appropriately, is associated with precipitating death. And this idea of double effect, which means that we give something with an intent and we accept a bad side effect, is not essential for justifying opioid use through the intent in and of itself. The intent is to manage the symptom and is not to hasten anything. So if we're using judicious dosing, then there's no issue with that. I wanted to touch really briefly on the concept of last dose effect. From a bedside nurse to a provider who prescribes, and I'm no longer giving those meds, I understand that there's a lot of anxiety from nursing sometimes when somebody seems tenuous and we're giving doses to manage symptoms, sometimes escalating doses. There will always be a last dose. That last dose doesn't mean that that was the dose that took that patient from the world or caused their death. It's just the last dose that was given prior to death. So, I think there's a lot of anxiety about, if I give this, does that hasten their time? If they're dying anyway, they're going to die regardless. So really not burdening yourself with that, knowing that judicious dosing was used and that you're helping to manage symptoms until somebody passes. Secretion management pretty quickly. We can see salivary or bronchial type. Turning, repositioning to side or semi-side could help. Gentle suctioning using the Yonkauer, but no deep suctioning for folks that are really at end of life with these retained secretions. It's more disturbing and doesn't necessarily reach all the way down there. Letting families know that, this is air passing through kind of these retained secretions. It sounds worse than it is. And we can use medications. Glycopyrrolate or Robinol does not cross the blood-brain barrier and is significantly more effective than atropine, but we can use atropine. Scopolamine patches, probably when we're seeing acute secretions and needing management, the patch takes so long to take effect, usually about 3 days to, 3 days to fully kind of kick in, or 3 days to be given, 24 hours to kick in and reach steady state. Then patches are usually not effective, or you need a lot more patch than when you're giving. So glyco or atropine would be preferred. If secretions are continuous, then scheduling those doses instead of waiting for PRN. Mr. W ended up dying shortly after with the family at bedside. Family was appreciative of symptom control, being able to be present. We helped with bereavement support kind of in that moment and through that day, and the patient was enrolled in a bereavement program. We were able to assist with memory making. We used little glass stones with a American flag or branch of service, and then the patient's thumbprint on the backside as a way for patients and families to have a keepsake. I know other places do lots of different things, but those are things that are meaningful for families. And so I think, again, just kind of thinking about that, you know, family wasn't able to cope, wasn't able to kind of accept that, but it was happening anyway. So we didn't force them to make any decisions. The man ended up passing with fluids and antibiotics running, and that was okay. But he had good symptom control, good family support. And it didn't change the outcome, but we were there to support them. So again, kind of getting back to, as much as we want to move forward to this new kind of idea of palliative, I think a lot of times we're still being involved really at end of life. If we have a very short time left, I have a video I would love for you all to watch. It's fairly quick. It's a couple minutes from the Cleveland Clinic. There's no audio, so if people are joining from phone, you're gonna miss it. But this is, if I can get it to play, it's a fantastic, quick little video. So thank you. I have a hard time watching that every time. But I think we don't know what folks are going through unless we ask. And I appreciate all the work that you all do every day. And wanted to carve out time if there's questions or comments, but also to thank you and just leave you with this Maya Angelou quote, which I love. People will forget what you said, they'll forget what you did, but people will never forget how you made them feel. So thank you for all your good work. And if you guys have questions, I'm still here if we have time.
Thank you so much, Cameron. That was really good. And that video at the end just kind of topped it off. And I just think that, you know, just what it said, would you treat them differently? You know, if you realize what people were going through, and it's just so important for us to remain connected and to be compassionate, you know, to our patients. And I think we do have a question. And this is, are we able to transition a patient to general inpatient status hospital in ICU while weaning pressors and preparing for compassionate extubation?
Yeah, thank you, Helen, for that question. I am not sure what practice setting you are, which facility, so that would really depend on kind of what your institution is doing, and whether their ability to do that. Usually that would need to happen within the ICU setting, but I won't speak to exact. And depending on, I think so much is dependent, and I think that's one of the hard things when making this presentation is a lot of things apply differently depending on your practice setting. So, you know, for example, the VA inpatient unit is a nursing home based unit, whereas MCV has a, you know, is more of an inpatient medicine unit. So those transitions can happen differently. So really understanding and talking to your palliative team and knowing what resources within your building and your practice setting may make some of those clarifications. And I think there's always, you know, there may be hard and fast rules, but there may be also exceptions to make sure that patients have the care that they need.
All right. Yeah, thank you, everyone. So now we're going to go ahead and we're going to do our Zoom drawings, and we've got some prizes for our